so that's kind of it. So let's go on ahead and apply this stuff now to some questions. Most of you are convinced, 2/3 anyhow. Just in terms of language, here's headache. And the key thing here is very high blood pressure, secondary hypertension. When you see values like that, patient can have headache. Notoriously not giving the potassium value, they're giving you the equivalents. No brewery, right? So they've excluded renal artery stenosis. Hypoperfusion is a cause of that high aldosterone level, right? You hypoperfuse the kidney, high renin, hyperaldosteronism. So they're telling you it's not renal artery stenosis. Negative data matters. Low plasma renin activity. That's how it's described. That's the test. It's called renin activity. It's just not renin level. Secondary hypertension, right? Renal failure is a cause of secondary hypertension. FeO is a cause of secondary hypertension. So this is clearly the language of both secondary hypertension, and they're telling you at this point, because they've excluded other things, this is how they're going to get you to the hyperaldo. And so again, I think hyperaldo, everybody's going to recognize the idea hypokalemia, metabolic alkalosis, and then it just becomes, how are we going to have a fist fight over what the sodium is doing? So a high sodium, the point about aldosterone escape is not part of the criteria. That hyperaldosteronism is manifested by hypertension, low K, high bicarb, normal sodium. I think it's the last time I'm going to do that to you. And again, it's just this guy. I love this little fella here. And that was my whole point about the adaptation. High aldo from, Conn syndrome, secreting. Your body ultimately stops reabsorbing all that extra sodium. And you're hypertensive because your blood volume is set at a higher level. Students do well with it. And, oddly, it's not an easy question. You guys are good that way. But again, here's the language of hyperaldo. Hypertension, low potassium, they happen to give you the symptoms too. And here they actually told you the renin activity is high. That renin level is inappropriate for that level of blood pressure, right? So autonomous secretion, you'd expect a low renin, but this high renin has to be coming from someplace. A reninoma, juxtaglomerular cell tumor, inappropriate. So if you had an adenoma, renin would be suppressed. FeO, the renin would be suppressed. So the high renin made this a rare tumor. You guys do good with that question. Take home is Endo is about functional studies first. Make the diagnosis. Here's the footprint. Hyponatremia, I gave you the low CO2, so now we have non-antigot metabolic acidosis, and they have hyperkalemia. So it's the footprint. They set you on up. Polymyalgia 6 months ago, put steroids into the picture too. They're relatively hypotensive. And here you have a little nodule on the chest CT. The nodule on the chest CT is to make you think, oh, paraneoplastic, maybe there's high cortisol, something like that. But this is the language here of adrenal insufficiency. So you have to make the diagnosis. ACTH stimulation test is the diagnostic test. Random cortisol, if it's lowish, it doesn't tell you the patient has adrenal insufficiency. ACTH, once you decide the patient has adrenal insufficiency, you can start teasing out the causes, and then you can get an ACTH level. But everything with endocrine is about functional studies first. I said we're going to do the ACTH stimulation test, which we did, and the patient had a pulmonary nodule. And why did they have adrenal insufficiency in the setting of the pulmonary nodule? It's another example of an infiltrative disease of the adrenal gland. The reason I'm harping on the infiltrative diseases, because if they give you Addison's disease, adrenalitis, lymphocytic adrenalitis, you're all over that. You're all over that. That one's easy for you. I just want to alert you to the second other kind of consideration that's going to give you adrenal insufficiency. So it would be too easy for you guys if it was just straightforward Addison's. Sorry, that's how we play the game. Good. So we can be brief on this. Failure of secondary sexual characteristics for female failure of menarche. And it winds up being XY, a male with ambiguous genitalia. And in fact, on the boards, that's ultimately how they present with failure of menarche. And so in this instance, it's a male who was deprived of androgens. And ultimately, then what does that mean? You have failure here. It's increased this pathway. And so in this case, the patient had hypertension as well as hypokalemia. So they snuck in quietly that they had hyperaldosteronism buried in this. So you did good there. This one gets you the whole shebang there. A 12-day-old hypotensive, tachycardic, hyponatremic, hyperkalemic. By definition, they're basically describing, right? They want you to look at the hormones. So they're telling you it's adrenogenital with failure of what is going to be 21-hydroxylase. So if 21-hydroxylase is in the toilet, what don't we get? Well, again, this is adrenogenital. Everybody has decreased cortisol. We're not getting here, so decreased aldosterone. ACTH is high because of the low cortisol, failure to synthesize cortisol. And now on this pathway, what else do we get? 17-hydroxy progesterone and increased testosterone. So just another footprint of a aldosterone failure. All right, well, that's it. That's what I have on aldosterone.